Hi, so I'm Daniela Altman, CEO of CX Precision Medicine. So just a little bit about my background. I am part of the Ivy network in that Harvard undergrad, econ major, Yale MBA, started my career at McKinsey, was here in New York for a while, and have really spent the last number of decades leading innovative healthcare companies. So the first half of my background, I can relate to all the physician comments because I came out of the payer provider space, healthcare services, negotiating managed care contracts and leading companies in that space. The last half of my career has been in life sciences, in a pharma company, and now leading CXPM. So I'm excited to tell you about it. So CX Precision Medicine is using AI, advanced machine learning, to develop blood-based diagnostics and transform how patients with neurodegenerative diseases are diagnosed. All of our technology comes out of Dr. Sid O'Brien's lab. Sid O'Brien is the most funded NIH researcher in blood-based biomarkers in Alzheimer's and predictive modeling. So he's had $250 million of NIH funding over the last 10 years in the university to build a massive biorepository, proteomic imaging, fully valid patients that we have been licensed from. So obviously, Alzheimer's is really, really a horrible disease. It just strips patients of who they are as people. It puts an enormous care burden on the entire family. The problem that we're trying to solve is there's also no easy way for primary care physicians to triage the growing number of Alzheimer's patients. So everywhere we have an aging population, and that fuels the increase of the number of people with Alzheimer's and related dementias. Early symptoms of the disease look like a lot of other things. Memory loss is prevalent. There's no one test to figure out that somebody has Alzheimer's. It's a very complicated diagnostic process. It's performed by specialists. It's 6 to 12 months to be able to get a referral to a cognitive neurologist or a memory center, and those wait times are increasing. And they're increasing in part because the great news is we finally have some new drugs that have been approved that can modify disease. So now there's promise to people, but they don't work for everyone. You need a full evaluation for that. But that's really increased the number of people going to their primary care physician saying, oh, maybe I didn't think there was anything I could do, but maybe now my mom, I'm worried about her, my dad. So that's really fueling things. So our solution is a blood-based test at the primary care level, and I should say in patients that have early symptoms. So this is not a screening test for everybody. It is for symptomatic patients that are 60 and up that can rule out Alzheimer's and related dementias. So on this chart, all these things in blue are things that can cause something that might look like early memory problems. It may be stress and anxiety. It may be sleep apnea. It may be that they have some metabolic conditions. It might be that they're having a bunch of CBD gummies before going to sleep to help with their sleep issues. So there are a lot of those things, but if you can figure those things out at the primary care level, you can keep somebody at the primary care level because those are all things that by and large can be evaluated and treated there. The one in the maroon, Alzheimer's disease and related dementias, are the things that really need that specialty referral and evaluation. So all of our tests are using advanced machine learning. So it's not using text-based languages. So these are just really super statistics that can run big data that are trained on a very large database that was the one developed with all of those millions of dollars of both cognitively normal and Alzheimer's patients. So we're obtaining a blood sample. We're measuring a very broad range of proteins, 21 proteins, We then analyze those results with a proprietary algorithm that's been trained using that database. Yes.
So can you define Alzheimer's? Because I think that a lot of diagnosed Alzheimer's isn't like what you call genetic Alzheimer's.
No. So that's actually, in a way, a complicated question because that definition is changing. So the reason I'm saying Alzheimer's and related dementias is because of that change. We rule out Alzheimer's and related dementias. The research community is starting to say Alzheimer's equals amyloid pathology, whether someone has clinical symptoms or not. Our patients that we're looking to help at the primary care level have symptoms, but they may or may not have amyloid tau pathology. I'll talk about that in a minute too.
There was a professor at UCLA.
No, the professor is at, believe it or not, at University of North Texas Health Science Center.
I know who you're talking about right now, but there used to be a guy at UCLA who had published a book on all these protocols for Alzheimer's and Parkinson's. And is this are the solutions coming out of this protocol oriented, or are they therapeutics, or
they're really coming out of so the databases that Sid has done 150 million of that funding has been a very large study that's sort of like a Framingham study except for the brain. So it's the ABS-HD study. It's NIH funded. There's about 17 research institutes. I don't know if UCLA is one of them or not, but the key principal investigator is Sid, and 100% of the evaluations are being done in Fort Worth, and it's tracking 3 equal-sized cohorts of non-Hispanic whites, Hispanic Americans, and African Americans, because the pathologies differ by ethnic group. So even though there's a bunch of research institutes involved, all of the workup, the biomarker, the lab, the neurocognitive testing, the imaging is all done at Fort Worth because Texas has a very diverse population you can recruit. Yep. So anyway, the algorithm then does the disease rule in, rule out. Let's see, the other way. Okay. So NeuroFirst Memory, which is the name for our blood test, is the first and only blood test that rules out Alzheimer's and related dementias at the primary care level. Take the test, there's 2 results. You're either ruled out, which means then that primary care doctor can look at all of the other things that might be causing those symptoms. If you're ruled in, it does not mean you have Alzheimer's disease. It means that that's who you refer up the line to have a cognitive assessment, to have your brain pathology tested. So there are a lot of technologies. It's, you pick up the New York Times and probably once a week there's an article and someone has something new in Alzheimer's disease. It's an area of great interest. We have a lot of competitive advantages at the primary care level for other types of technologies. First, as a blood test, it has 2 big advantages over cognitive assessments or optical scans. It fits into existing practice workflow. I used to run doctor practices because primary care is a production shop. You have to get a lot of people through there. You can't take that extra 5-10 minutes to do a digital cognitive assessment. Secondly, insurance companies pay for blood tests. They may not pay for non-symptomatic tests that are screening tests, but they pay for blood tests that are that have symptoms attached to them. Secondly, among the blood tests, we can rule out Alzheimer's and related dementias based on both brain pathology and cognitive function. We believe that the NeuroFirst Memory test is more effective for primary care physicians to use than other Alzheimer's blood tests. So there's a lot in the news on beta amyloid. I think this gets at Marty's question a little bit, and p-tau 217, and so many of the other types of markers. And those are great markers to figure out whether one of the new drugs will work for you or not work for you. But if you're a primary care physician trying to figure out who do you assess for memory tests, they don't tell the whole story. And it's because 25% of patients that have clinically diagnosed mild, moderate Alzheimer's based on cognitive testing have no beta amyloid pathology at all. And that's especially true in diverse populations. And there's a bunch of other therapeutics people are working on that are targeting neuroinflammation, metabolic, other types of conditions and therapies. So if a primary care physician, ruled people out just on beta amyloid, those patients would not get evaluated. Secondly, about a third of cognitively normal people that are 70 and up have this pathology. So they're cognitively normal. They don't need to, at this point, be evaluated further. Primary care doctors really recognize that blood tests are going to be critical in diagnosing and treating Alzheimer's. So this was a survey that was of the American Academy of Family Practice and also Gerontological Society of America. Hardly any of those physicians are currently using blood-based biomarkers for Alzheimer's, but for almost 100% or 100% for family practitioners say that they will use that in the future. The payers would really save money as well, because that evaluation at the specialty level, ruling out a lot of things, doing advanced imaging, other types of testing is very expensive. So about 80% of people roughly who take this test that have symptoms are going to be ruled out. So they're not going to have to go through the costs of kind of step 2 through 4.
Go slow here. Can you
Yep.
start the prior slide and
Yep.
a question from the audience about the test, the cost of the test?
Yep. Yeah, yes, there is a question.
Covered by insurance?
Is it covered by?
Insurance?
Not yet, but
That was
it
my
will,
question.
not yet, but because we have to do the pilot studies, but we have done the coding strategy. We've done all the workup on the economics behind the slide in a very detailed model of how that would work. We've also
Well, no,
done
I-
the crosswalk on Medicare on how much the payment would be.
Question is whether it's covered by insurance. If there, of the tests that are given today, is there an insurance code for the existing test?
There are, we know we would get a specific type of code that's specific to our test.
Yours, right,
But-
doesn't exist already for the existing test.
Not for the amyloid beta test, not for those blood tests in general. They're,
Insurance doesn't reimburse you for that?
we are raising money to do the pilots. And so we don't have revenue from our tests. We can,
So I know what you're talking about.
right,
I'm saying, take a step back.
right, to C2N or
On
what
the existing tests that exist, they must have insurance codes.
they have, some of them do and some of them don't. There's some generic codes people are using. So you can always use the generic codes. Some have specific codes. So it's a mixture of some generic codes and some specific codes depending on the company.
That's a question in the funding world.
Okay,
If you have an insurance code, it's easier to get funded than if you don't.
yes,
Robert?
So you're not FDA approved right now?
we're very close. So we have, under the regulatory rules, we can, we're completing what's called the validations in a CLIA lab, so we can launch as a lab developed test. And those are very close to being done, should be done first quarter of next year. If we didn't have Christmas, I could almost say end of the year, but I think it's going to slow down. So the beginning of next year. So at that point, we would be able to offer our test legally. A physician could order it, but insurance would not pay for it yet. So there's a process you go through to get Medicare reimbursement. We have a good idea of what we would be paid under Medicare. Yes.
No, go ahead, please.
I understand from the former slide that that lack of sleep or sleep induced by some CBD or whatever. Sorry. Do I understand from the former slide that lack of sleep
Yep.
or sleep induced by CBD or some other kind of
Yep.
is one of the major causes
It's not a cause, but it can be, it can be mistaken for. So that's the thing. If somebody has sleep issues, it can really cause memory issues. And it tends to be that primary care doctors and families will say someone's older. Maybe if they were 40 and they weren't getting sleep and they're forgetting things, no one would worry about it. Now somebody is 70 and their sleep is messed up and they're forgetting things. They're worried then about Alzheimer's. And it may be a sleep issue, but sometimes the primary care docs don't really evaluate the sleep because, like, okay, well, you're a certain age, maybe it's that. So, but the sleep issues can be reversed. And I saw a really interesting presentation at the Alzheimer's International meeting this summer, where a group was testing insomnia drugs in clinical trials, and they started seeing less dementia over the years in what they thought was dementia. And so actually, if you fix the sleep issues, your brain could clear, and these are people with amyloid pathology, they could clear out the amyloid. So it's complicated.
Wonder if pilots and people that work late night shifts at emergency rooms
Yes.
are more susceptible because.
Yeah, there was
they-
actually, I saw a presentation on that too. There's somebody in England did a study of that. And I think that there was a correlation, but then when they stopped, it cleared out after a while. So it's interesting. I haven't read the paper on it, but I saw a presentation on it. Yep.
If I understood correctly, it's not CLIA certified yet, but it's been validated.
It has been validated in the academic environment. The analytical validation has been is 99% complete. I think we're waiting on one piece of that. The clinical validation, we've got the samples ready to go because you need an independent source of samples. So that's being done in a CLIA lab. Okay. So yeah, I've been in this industry a long time on both parts of it, and I'm a fairly skeptical person. So actually, a lot of times don't believe when people would put stuff up and say this could be $1 billion company, whatever. I actually think this could be. The primary care market is huge, and that's using fairly conservative estimates of the size of the TAM. Another way to look at it is if you only have 1% of people 65 and up that get this test annually, it's about $500 million of revenue a year. We have a good idea on what the reimbursement for the test would be. I should say, since we had questions on that, the way Medicare does this is they basically look at your costs so they know what kind of equipment you run on, how many biomarkers you are measuring, what the algorithms are. So we have the comparable list of other tests, but they're not Alzheimer's tests. And so it's going to be between 750. You could bring it maybe up to 1,200. We know what the COGS would be. There's also an opportunity for partnerships because primary care really drives the revenue downstream, whether you're imaging, your pharma, your other types of things. And partnerships could also lead to acquisition opportunities down the line potentially as well. Also, there's a number of the oncology companies that have gone into liquid biopsies and they've developed and they've raised a lot of money. So they've gone out and put in sales forces and everything else. So there's some potential to partner there as well. So we have a robust pipeline. We're starting with the Alzheimer's test. We actually have, it's published really terrific results from a Parkinson's test. So similar rule out for people that have suspected Parkinson's. Usually they're younger, 50s, not 60s and up, male more than female, essential tremors, other types of gaits, some other things that are indicative of Parkinson's. Also to rule out Parkinson's, subtype tests, Lewy body dementia rule out. We've licensed all those. So CXPM, we have an exclusive license both to the IP and to the algorithms that are behind this technology. 4 patent families, a number of issued patents. We've raised a little over $7 million since 2020. We talked earlier today, someone was talking about fractional teams. We have a really highly experienced team of people that have worked in this industry, have a lot of experience in kind of key components of the team. We've also partnered with expert groups that are doing different pieces of the business system. So reimbursement, regulatory, bioinformatics. And we've been involved in industry organizations, the Global CEO Initiative, Davos, and we're one of the Alzheimer's Moonshot community companies. The analytical and clinical validations are expected to be done shortly. We've done the coding strategy, completed the budget impact model, started talking to Medicare and payers, and then figured out, had a lot of discussions with physicians about how this would fit. So the plan is next year to really do pilots. So we're not planning on kind of a big national launch, on some select concierge practices and a select payer or so that we lay the groundwork to get that insurance reimbursement. There's another conversation we had on FDA regulations. We're very aware of them and working on those and complying with those as well. We want to get Parkinson's up and teed up and moved over to the commercialization environment and the CLIA lab. And then there's opportunity to work with pharma. So we have a $4 million round that is open. We've closed on almost $1 million of that at this point. It would be funding the pilots for Neuro First Memory with payers and concierge practices, and then supporting what we need to do over the next year in order to gain reimbursement. And we also want to move Parkinson's from the academic lab and have that go through the CLIA validation.
Like what concierge practices would you be working with?
We only want to work with a couple, and it would be Texas-based would be the easiest for us. So we've started having some conversations. We're waiting till that validation is done before cementing anything. But mostly we want to make sure that the reporting is meaningful. We get the feedback from the physicians that it fits the way that we want it to fit. And that also helps build a story for reimbursement as well.
I was wondering if you had like contact NYC, which is this huge network.
Yep.
They're big in Dallas and concierge doctors.
Yeah, I actually, one of my board members is Charles Bank Partners is one of the investors in there, and so at the right time, getting connected with them makes sense. We're doing small volume for 2025.
There's an online question about what's your current valuation?
We've closed, the money's been closed to the 30 million pre-money. 7.2, though that probably doesn't include the extra amount that's come in already into this round. It's high net worth individuals by and large. We have a number of Texas family offices that have been very, very supportive of us. I'm not the founding CEO. I was actually hired by the board in 2020 to kind of move this forward. And
right, you've got a private equity firm in Dallas that is guy's a doctor and a Harvard MD.
So we have not closed with private equity yet because we don't have revenue yet, but we've had a lot of interest from private equity given where we are because we're so close to commercialization. I mean, we'll have.
So what was your post valuation, your prior round?
My 28 and a half.
Okay.
Yes. Yeah, we're going on a lab developed test route. So LDT, which is a FDA, it's governed by a different part of CMS under CLIA regulations. So, we'll see with the election result what that means under President Trump's first term. And because COVID tests were not getting out, he had an executive order that said FDA has absolutely no jurisdiction over lab developed tests, like none. And it's only going to be regulated by the other division within CMS. The Biden administration this May came out and said, actually, no, the FDA does have jurisdiction and there's a 5-year roll-in of that regulation. I don't know if that will stand the new environment or not. I can do frankly either. I mean, it's just that one will take more money and more time and the other one doesn't, but they're all workable. Our CLIA validations are being done in Biotechni's lab, Assuragen, which is in Austin. They have both LDT and IVD products. So we're not a little tiny lab. This is also built on the Luminex as a platform. It's super scalable, multiplex immunoassay. We don't have the volume now, but it's scale. And actually, Dr. O'Brien's lab at university is running this with Hamilton robots, massive, it's really scalable compared to a lot of things. So you can run thousands of tests, which you need for primary care because it's a huge market.
What's the revenue model?
The revenue model is initially, I'd really like to have the direct sales force and be able to go directly to concierge practices and certain healthcare systems directly with my own sales force. However, there's opportunities to license with others over time to be able to really have the broad reach because there's a ton of primary care physicians. So in one model, I would have all that revenue. The revenue would come in to CXPM. Under other model, it would be a licensed model, so I'd get a portion of it.
I mean, like an MDVIP has, 1,500, 2,000 doctors.
Yep.
Each one has 400, 500 patients.
Yep.
And half of them want this test immediately.
They'll want this to test immediately, and Parkinson's too. Parkinson's is a similar test, younger demographic. Both of these diseases, they're horrible diseases and people really worry about them. And if you can catch them early, you can at least stave them off. You can do a lot of things. So it can really help.
I own a concierge practice. I know that people come in and they're calling you day and night and they are afraid of anything.
Right. So that's,
And the amount of relief they get from having a test is phenomenal.
right. And most people will get a peace of mind relief answer and hopefully identify some of the other things. Some people will be anxiety, but there will be people that have other things that are going on that are legitimately causing some cognitive issues. And if you can catch those and actually flip them, that would be terrific. Hearing is a big one because people don't think that they have a hearing problem, but they kind of do have a hearing problem. And then their child will say, I told mom that 3 times and she can't remember it all. She must have a cognitive issue. Well, no, she just never heard you in the first place. So if you can correct some of those things, it makes a big difference. So I mean, for us, I think we can make a big impact and not just financially.
Is there a market potential diagram chart here somewhere? In terms of what's the size of the market for this?
I put 3 billion. I have it in our deck. I don't have it in this slide, but basically we looked at the incidence and the prevalence in terms of how many people have percents of memory concerns. And we looked at the number of people that are diagnosed per year. And so if you take about 10% of people that existing have potential systems as part of the target addressable market, and then you take 50% of the new people that come up, because the research shows about 50% of people that have concerns will talk to their doctor about it. So we didn't take the whole market. We cut it back to 50% of new cases, 10% of existing cases. We used what Medicare would currently pay. That doesn't mean that you couldn't charge more in a private environment, but we have a good idea of what Medicare will pay. And that's how we got to, and that's US only for 8 billion. So it's a lot. But I do have all the granularity on it, just not on the slide for today. Okay. Yes.
Talk a little bit about the process of reimbursement, how you set yourself up for that.
Yeah.
Obviously, you're doing it in parallel till the end, to the LDD.
Yeah.
A little bit about how you plan to get a CPT code?
Yep.
And is there existing CP2 codes already for what you do? Any other tests that you'll be able to add to that? Or you
I
have to
don't think,
create a
I
CPT?
don't think that is a strategy. I don't think it's the best strategy. We did a whole coding strategy for lab services. There's something that's called a PLA, a proprietary lab code that's proprietary to us. And the AMA quarterly takes applications for that, but we do have to have the CLIA validations that are done. So it's quarterly. Could we make March? Maybe. If not, it would have to be June. So basically, you submit for the AMA. Alva 10, which is the group we're working with, has huge experience on this. They've done it many, many times. I don't think we're going to have any issues at all getting a PLA code. And then with Medicare, our lab, then it gets kind of granular from there, but Medicare both has a national determination and it has local Medicare groups. And we've had discussions with the groups that overseeing Texas in terms of being reasonable and necessary. And so you have to go through the process of getting a price set for that. But I'm feeling pretty confident about that. And we've had discussions with other Texas-based groups like Castle Biosciences is publicly traded. They, have gone down the LDT route. So it is there is a tried path on here.
Two codes, we get a national determination code, and then you get the.
Eventually get the national one. We'd need that to probably for the national one, that's a longer path. But as an LDT, we can only do the test in one location anyway. So it would have to be sent over to be analyzed in that test. And the bioinformatics and the bioanalytics are being done. So for us as an LDT, we don't need that national determination, just a local one. In this case, in Texas, which is not a unfriendly state for being able to work with. So
If you get that in Texas, then all of the samples can be mailed and processed in Texas.
yes, except for New York. I hate to say it because New York has its, oops, sorry, that messes it up. New York has its own rules, but everywhere else in the country could mail it to Texas and it would be from a Medicare standpoint processed in Texas. So it's not a barrier. It goes through Novitas. Okay. All right.
Anything else? Great job. Thanks so much.
All right. Thank you guys.